Hi everyone, I am Dr. Madan Pandian from India. Today we are going to discuss a case of complex regional pain syndrome following a stiff shoulder for which we performed a stellate ganglion block for pain relief. A 56-year-old diabetic lady with history of right shoulder pain over the last 2 years presented with increasing pain and stiffness, particularly at night, who was unable to do household work. She developed upper limb swelling and pain along the entire limb the last 6 months. On physical examination, the shoulder was painful, particularly on abduction. There was a painful arc. The O'Brien test was positive, and the external rotation was extremely painful. The right upper limb was entirely edematous, shiny, and a little pale in color, which was suggestive of a complex regional pain syndrome secondary to the shoulder pathology. On evaluation, she had poorly controlled blood sugars, HbA1c being around 9. The X-ray showed a superiorly migrated head of humerus, which is suggestive of a rotator cuff arthropathy. The ESR, CRP were normal. The nerve conduction study again was normal. The screening Doppler, particularly in view of the limb edema, had to be done, which was normal. Differential diagnosis. In view of the shoulder pathology, it could be anything related to the shoulder related pathology or an adhesive capsulitis, and possibly a cervical radiculopathy also needs to be ruled out. With regard to the limb edema, a diagnosis of CRPS is largely clinical and one of exclusion. The differential diagnosis for the limb edema being a sensory motor neuropathy, sometimes a cellulitis, vasculitis, a vascular insufficiency, deep vein thrombosis, or sometimes rarely Raynaud's phenomenon. All these differential diagnoses must be kept in mind prior to planning an intervention. With respect to the examination of the shoulder pain, and high resolution ultrasonography was performed as per the ESSR protocol, where rotator cuff tendinopathy, adhesive capsulitis, and an AC joint arthropathy was present. In this particular patient, why do we require ultrasound examination at all? One is to identify the shoulder pathology and thereby treat appropriately. Then, to guide a good stellate ganglion block, thereby we can reduce the limb edema and centrally mediated pain. The diagnosis in this particular patient is an adhesive capsulitis of the right shoulder. Because of the continuing disproportionate pain, there is always a possibility of a complex regional pain syndrome. We arrived at a diagnosis of CRPS based on the Budapest criteria. The diagnosis of CRPS is largely clinical and one of exclusion. With the continuing pain which is disproportionate to the inciting event, there is always a possibility of a CRPS. Looking at the signs and symptoms of this particular patient, the symptoms must be there at least one of the 3 or 4 categories which are shown here. There was allodynia, changes in skin color and edema in this particular patient. And on the signs, the allodynia and edema were sufficient enough to clinch a diagnosis of CRPS, particularly with the presence of no other diagnosis which can explain the patient's signs and symptoms. Following interventions were planned. The stellate ganglion block was to be performed after a feasibility study, followed by the shoulder interventions after a gap of 5 days. Prior to the stellate ganglion block, a fasting blood sugar, Doppler study, and a vascular surgeon's consultation was performed. An X-ray shoulder was done to rule out any other pathology. These were the possible interventions: an ultrasound guided stellate ganglion block with local anesthetic and dexamethasone, or a fluoroscopy guided radiofrequency ablation of the T2 sympathetic ganglia. Performance of a stellate ganglion block under ultrasound guidance requires a lot of precautions. The foremost being a feasibility ultrasound study to look for the structures at the level of C6. At the level of the cricoid, identify the transverse process, the anterior and the posterior tubercle between which you have the C6 nerve root, and identify the longest colli muscle, the great vessels, the carotid, internal jugular vein, and obviously look for the thyroid and the esophagus as well. Try to identify the potential target space, that is the prevertebral fascia just above the longus colli muscle, and try to identify the potential safe trajectory to arrive at this target. While performing the feasibility ultrasound study, it is not just enough to look at only the C6 root. Always try to look for the C5 transverse process, wherein the anterior and the posterior tubercles are equal in size, and in between you have the C5 root. Always look for the C7 transverse process, where there is an absent anterior tubercle and a posterior tubercle which is very prominent, and you have the vertebral artery and the C7 root very close by. Not to mistake C5 and C6 while giving the stellate ganglion block. The stellate ganglion block must be performed always inside the operating room with utmost safety, with usage of monitors like electrocardiography, pulse oximetry, non-invasive blood pressure and respiration. Always monitor the skin temperature with a special probe both before and after the procedure. In our patient, actually, we have used the infrared thermometer to measure the skin temperature both pre and post block. A difference of 1.5 degrees Fahrenheit means that the block was successful. The best position of the patient, the machine, and the interventionist is key for a successful stellate ganglion block. The patient is supine with the head turns towards the opposite side. A linear transducer is used. The machine is kept just opposite the interventionist. The needle is introduced from lateral to medial in an in-plane technique using a linear transducer through the window posterior to the carotid and the internal jugular vein. The target area is deep to the pretracheal fascia but superficial to the longus colli muscle. Because the procedure is not as such performed at the C7T1 level, cervical sympathetic chain block would be a better terminology for this technique. The power Doppler should always be on prior to injection to prevent injury inadvertently to the inferior thyroid, vertebral, and the carotid arteries. But beware of a lot of artifacts, particularly when you use color Doppler mode. This is exactly the picture any interventional pain specialist would like to have. At the C6 level, you could see the longus colli muscle, and there is a drug which is spread just above the longus colli muscle in the prevertebral fascia, so that the drug will descend down to the stellate ganglion level, which is at C7T1. Stellate ganglion block is one intervention where the patient can develop multiple side effects and complications potentially. Bruising or soreness at the injection site, there is a drooping of the eyelid, red short eyes, watery eyes, nasal stuffiness, hoarseness of the voice, a feeling of lump in the throat, and a difficulty in swallowing, which all can occur as side effects of a stellate ganglion block. But do we call it just side effects? No. Essentially, this indicates the success of the stellate ganglion block. Beware of the following complications like vascular puncture, the carotids, the internal jugular vein, the inferior thyroid artery, and the vertebral artery all lying close by. A neural puncture means like you can actually hit the vagus, the recurrent laryngeal nerve, or sometimes the brachial plexus roots. A pneumothorax, thyroid injury, esophageal and trachea puncture, a transient Horner syndrome, or an intravascular injection of local anesthetic. All these can lead to potential complications. That is the reason why you need a lot of monitoring during and immediately after the procedure. This particular patient developed a transient Horner syndrome and an increase in limb temperature post procedure, which was suggestive of a successful stellate ganglion block. Post intervention, always observe these patients for at least 6 hours with all the vitals monitoring. Keep the patient nil per oral till the hoarseness resolves. Always use ice pack at the needle site for pain and swelling. Essentially, this is not a true stellate ganglion block. This is exactly given at the cervical sympathetic chain level. Secondly, treat the primary cause of CRPS for better results. We reviewed this patient after 5 days of the stellate ganglion block. The upper limb pain had reduced by around 80%. There was no limb edema and the temperature on both the sides were comparable. After 5 days, the patient underwent all the shoulder interventions, a subacromial bursa injection with dextrose, a saline hydrodistension with 40 milligrams of triamcinolone, and a gentle shoulder mobilization was done till the patient permitted. A 90% shoulder pain relief with a better sleep at night was reported by the patient after 15 days of the procedure. There was no limb edema. Thank you.